This is a special situation now. You got a cataract surgery in a functioning filtering bleb situation. Here there are two problems that one has to think of. One is phaco machines require a certain amount of pressure to be maintained, and because of the leak that we've actually created, you'll have a 360-degree chemosis and the pressure refuses to go that high. Two is you've got a perfectly controlled IOP to start with, and you've hydrodissected the bleb, and next you are dealing with a hypertonic. So both of which, basically, we are trying to protect the bleb. There could be scarring because of the extra inflammation, because we have sent lens material into half the trabeculectomy patients have visually significant cataracts by 5 years of time anyway. Most of those cataracts form within the first 1 year. So usually, I'll just skip a few slides. Okay, this is the specific situation which I was talking about. You can have a 360-degree chemosis, you can injure the bleb. So be careful when you're putting in the speculum. Especially those bubble-like mitomycin blebs, if you tear it, you're in trouble. You're looking at conjunctival advance, and what you promise the patient as a 10-minute surgery will turn out to be a 1-hour surgery. Endothelium has to be protected because it's a second surgery. Any intraocular surgery gives it a beating, be it trab or cataract. So it's a second surgery. And use an instrument designed for conjunctiva, not a fine forceps, not a non-tooth, Hoskins. Hoskins is the least traumatic instrument that can be used, and that is the way to go about it. You don't want to have a straight tear even 2 clock hours away from the bleb. It may still start leaking. Paracentesis should be the first step because you've got to have the control of the anterior chamber, and gives you access to the AC to do all sorts of maneuvers as and when they come up. And it should be slow and deliberate. You don't want sudden decompression and things like that. This is something that I do, and I believe it works. You block the ostium at the start itself with something like sodium hyaluronate or something like viscoat, which will stay there, not HPMC. HPMC will slowly dilute out. It's a double-edged sword because if you leave these behind at the end, IOP can go out of control. And OVD anyway will get into the trap while you're putting it into the anterior chamber, make it controlled, and useful to you during surgery. So for that, once again, just like I've mugged up the area of the trab ostium like I showed in the previous video, go right there and inject a blob of Helon or sodium hyaluronate, and rest of the AC is filled with HPMC, and we continue with cataract as usual, and usually the bleb doesn't expand. And the other thing is, once you put something there, you need to take it out at the end of surgery. So one has to deliberately go in there and aspirate it out. I think I went on to the next one. Anyway, one has to go into the ostium, like so. Get rid of all the visco devices that are sitting in there behind the IOL, etc. But finally, you have to go in there and try to clear as much of it as possible from the bleb without traumatizing the bleb. Of course, you hydrate at the end of it. Do not overinflate. Check the IOP at end of surgery. These guys may be at the edge of going wipeout. So IOP should be normal, AC should be formed, and that's it. I always finish with a little bit of air because I still don't know whether it's going hypertonic and all of it's going to go into the bleb. It can collapse the AC. Post-op, check IOP the very next day at least, maybe high, maybe low, medically manage that. Retain visco, inflammation, all this can send the IOP high. Treat with short-acting drugs, preferably acetazolamide, mannitol if it's that bad. It's never happened to me. And overfiltration, leaks, etc. should be looked for because you could have injured the bleb with your speculum when you're taking it out also. Atropinize and management of shallow AC already I think has been taken care of with the hypertonic talk. Later on, one may have, especially the open-angle glaucoma people, one may have a steroid response coming in. It may not be only the trap that's functioning. The conventional outflow also may be functioning, and that can be compromised. Thank you.